I'm Dr. Hemvati Nandan, working as a cleft orthodontist in GSR Institute, Hyderabad. It's a beautiful city and it's a charitable, non-profitable hospital in Hyderabad, which is serving solely on cleft and craniofacial anomalies. We operate around 1,200 cases every year. We have 4 surgeons, 4 fellows in surgical team, and in orthodontics we have 3 orthodontists. And till now, we have 40,000 documented cases of cleft and craniofacial. Every year, around 500 primary newborn baby register to our institution. So as we are, I'm working as a cleft orthodontist in the center. So orthognathic is a part of the orthodontic treatment process. Once we will prepare the patient for the surgery, then they have facial disfigurement and facial asymmetry that have to be corrected with the orthognathic surgery. So broadly, we can divide orthognathic surgery in 2 parts, like a functional orthognathic surgery and aesthetic orthognathic surgeries. Usually in the cleft, functional and aesthetic both are involved. So whenever we are considering any patient for orthognathic surgery, we have to consider few points. Like first, we have to identify the problem. So whether it's because of the maxillary hypoplasia or like mandibular prognathism or whatsoever, whether mandible is not grown properly in the class 2 kind of cases. So once that problem is identified, then we have to formulate a preliminary treatment plan. So whenever we are like, if you'll see these both cases, they are having the maxillary hypoplasia almost similar. If you'll see in the second case, the maxillary hypoplasia is more. In first case, maxillary hypoplasia is less. So first we have to identify what treatment plan we through which treatment plan we are going to go. Like first case, if you will see that CVMI index is showing that a lot of growth is left. In the second stage, you can see with the CVMI index that growth is almost completed. So the treatment plan will be different for the both the cases. So if you'll see this first case, we have done with the growth modification, and you can see that maxillary hypoplasia is resolved a lot, and there is a improvement in the facial profile. So if patient is in the growing phase, we can take the advantage of the growth and correct these kind of problems non-surgically. So once treatment plan is established, that this treatment part we have to follow, then we have assessed the patient motivation, whether patient is motivated toward the treatment or not, because in the cleft or any orthognathic treatment, it's a long-term treatment. First, we have to do the orthodontics for preparing the case for the surgery, then surgery, and then again followed by orthodontics. So it's a long-term treatment plan. So whether patient is willing to follow that treatment plan or not. And at last, we have to see that the treatment is feasible or not, because we are living in the city where every patient can't afford the treatment, because sometimes that treatment cost is very high, sometimes that center is very far, and from our side also we can't sponsor the treatment to the everyone. So we have to check the feasibility of the treatment for the patient. So once it's established that we are going to do the pre-surgical orthodontics followed by orthognathic, so there are few steps which we follow. So treatment sequence is, we will take the clinical photograph, we will do the clinical photographic analysis or clinical assessment, then we will do the model analysis, cephalometric analysis, then pre-surgical orthodontics, and then orthognathic surgery, and then post-orthognathic settlement. So like whenever patient enter to our clinic, we assess them clinically, and later we can assess them on the photographs also. If you'll see in this photograph, there is definitely maxillary hypoplasia. But if you'll see the cheek curve, there is a double breakage in the cheek curve, which is showing that uh, it's like maxillary hypoplasia and mandibular prognathism, which you can identify also with the lateral set. Because first time when patient report to your clinic, we have to clinically assess and give him some idea that what it could be, what treatment we are going to follow, and then we can write them him for further investigation like cephalometric, CBCT or something. So second thing is that we check for the facial symmetry, whether face is symmetrical or not. We draw a horizontal interpupillary imaginary line and then a vertical line from glabella, and that line will passes through the subnasal and menton. So, and face can be divided into 5 equal vertical part and 3 equal horizontal part. So in this case, if in this case you will see that it's visible, there is a facial asymmetry, jaw is deviated toward the one side. It's a case of TMJ ankylosis. If we will draw a imaginary line and see the facial asymmetry, we can see that face is shifted uh, toward the right side. But other than the deviation, there is other problem in the uh, facial proportion also. If you will see that there is a shortening of the lower facial height. So when we are making the treatment plan, we have to make a treatment plan like that. We have to correct the facial asymmetry and we have to correct the lower facial height also. So these are the post-treatment result. So second is the model analysis. Whenever a case will report to us, we have to uh, do the model analysis, and after performing the model analysis, we will figure out whether these teeth can be accommodated into the arch or not. So for every 1 mm of expansion, we get 0.5 mm of this space. So if you'll see in this case, it's a severely crowded, around 4 teeth are inside the palate. It need around 28 mm of this space because every premolar needs 7 mm of this space, and for lateral incisor also it need around 7 mm of this space. So by expansion, it's not possible to create a 28 mm of this space. And for every mm of the proclination, we get 2 mm of this space, and every 1 mm of retraction we lost the 2 mm of this space. So even with the proclination of the anterior teeth, it's not possible to get 28 mm of this space. And if we will extract those teeth which are palatally placed and do directly the maxillary advancement, then your molar is going to occlude with the premolars, and the posteriorly it will create a bigger space which can create a VPD. Other than that, occlusal table is not balanced, and if occlusal table is not balanced, that patient will not able to eat, then is not going to serve your functional problem. So we have done a Caslin setup and try to check whether we can accommodate all these teeth or not. So we figure out that we need around 20 1 mm of space on the one side and around 14 mm of this space on the other side. Then we align the teeth and created some space for AMD. We have done the anterior maxillary restriction with RED frame, and we accommodated almost all the teeth. We have left that lateral incisor because if we will create the space for the lateral incisor also, then arch become more asymmetrical, and on the left side there will be a space. And one thing, when we distract its bone is a when bone is got distracted, it also become thinner. It's like a candy. If you will pull it, it will become thinner in the central segment. Theoretically, it's possible to distract the bone to any extent, but clinically, usually it becomes thinner in the central part. It can give a good projection, but when I try to move the teeth into that distracted bone, it can pop up. Or if it will pop up, then there is no point of distraction for me as an orthodontist. So we have distracted. You can see the change in the arch length, and you can see the change in the facial profile. It's an intermediate procedure of the distraction, but it has given a good fullness. Now we are waiting growth will completed, and then we will reassess if any further treatment is required, like genioplasty, those things we can get it done during the rhinoplasty procedure. Other than that, for orthodontics, the cephalometric analysis is the most important thing. Whenever we do anything, we will do the cephalometric analysis. We love to play with the numbers and angles and see that whether these things can be done or not. So whenever any case report to us, pre-orthodontics also, we will do the cephalometric analysis and make it preliminary treatment plan. Because if we will explain our patient that this surgery have to be done and exact that surgery we are going to do, that patient will be happy and he has a good faith on you. So if you'll see this patient, if you will draw an perpendicular line, it's showing that maxillary hypoplasia is there because A point touches the n perpendicular line. So we will trace all the uh, landmarks which are not going to change after the surgery with the red, and with the black we have traced those landmarks which are going to change after the surgery. This is the osteotomy line, imaginary osteal line we had drawn on our CEF. This is the FH plane, and we have drawn a n perpendicular line which will be our reference line. This is our reference point. Maxilla have to come forward and this A point have to touch to this line. Now, actually, maxilla have to advance till that vertical line, but there is a overbite of 2 mm. So for that overbite reference, we have drawn this horizontal line so that this A point will come forward and this point will come here. Now we got a final tracing with our reference line, and this second one is our primary tracing. So we will slide the final tracing over the primary tracing till the time this A point will not touch to the n perpendicular line. So this is the final positioning of the forward positioning of the maxilla, but it's not final positioning because still we have not achieved the overbite. Now we will bring the maxilla downward by 2 mm. This will be the final positioning of the maxilla, but still if we will see, there is a overjet. This overjet is more than 2 mm. So these teeth needed to be retracted. We'll try to retract it back, and this will be the final position of the teeth. So accordingly, we can assess the need of space for teeth retraction so that we can plan that retraction prior. And according to the hard tissue movement, we draw the soft tissue. Soft tissue never reacted to the hard tissue. There is a like always 30% of change in the nasal tip and 50 to 70% change in the vermilion, and nasolabial angle will change 1 to 4 degree. But these things can be manipulated by the surgical technique, so that if we will give our colleague that idea that I have advanced this much and tip can be changed or the LR flaring can be happen this much, so during the surgery they can tighten the LR area by the LR cinch, so these problem can be sorted out. So this is a case of maxillary advancement. You can see that improvement in the facial profile on the CEF. These are the side profile views. This is the other case of maxillary advancement and genioplasty. If you will see, primarily the chin is looking very good. It's not look like that chin. It's that this girl need a genioplasty. Do you think that this girl need a genioplasty? It doesn't need a genioplasty, but if you will see the facial proportion, the lower facial height is very short, so genioplasty is required because we have to rotate the chin downward to increase the height of the face. So if you will see pre and post treatment photograph, you can see the changes in the facial profile, and even the facial proportion is restored. Pre and post surgical photograph of the patients. So pre-surgical, after this, once we have predicted the treatment plan, we go to the pre-surgical orthodontic phase. It need the labeling alignment. then decompensation, then coordination of arch. And once arch are coordinated, then the patient is ready for surgery. Then you can go for your surgical treatment planning. Sorry. Being a orthodontist, sometimes these kind of cases encounter into the our OPDs. Usually all teeth are in a single line and now they will come to your OPD and then you have to do something. These kind of cases, like if you will plan these kind of cases, they look very difficult, but they are not always very difficult. They can be treated easily. If you'll see, there is a post invert collapse of the posterior seg segments and palatal tipping of the anterior segment. So if you will see this treatment sequence, without extracting any teeth, we have aligned all the teeth, but initially we have started the derotation of the posterior teeth, then created a space for the other teeth, and then one by one we have moved the teeth. In this, we can't fix a continuous arch wire, because if we will try to fix a continuous arch wire, the anterior teeth will pop out because there is very less cortical bone support at the outer segment. So although the arch looked aligned, but teeth roots are tipped inward. Now in this stage, fistula was open, which was closed there. After this, we have done the bone grafting, and after bone grafting, we are start uprightening the root, because if we will uprighten our root to the augmented bone, then the uptake of bone will increase. Otherwise, if I will leave it like that only, in next 1 or 2 year, it will got resolved from there. So first step is labeling and alignment. So we have to flatten the curve of SPE. So flatten curve of SPE will give you the stable occlusion without any interference. And if there is no interference and proper flat occlusion is there, you will get a better stability. But when we are when we are preparing the case for orthognathic, it's depend on the different kind of cases whether we have to flatten the curve of SPE or not, because it's always not there that we have to flat the curve of SPE. Because if facial height is ideal, lower facial height and upper facial height proportion is ideal, then we will always flatten the curve of SPE. If there is a discrepancy in the facial height, then it's not always that we have to flatten the curve of SPE. So if reduced lower facial height is there with a deep curve of SPE, usually I prefer not to flatten it, or it's better not to flatten it, because when we advance the mandible, it will create a posterior open bite and it will auto rotate the mandible downward, which will increase the facial height. In this video, you can see when it's coming forward, it's increasing the lower facial height. And this posterior open bite can be settled post surgically easily with the elastics. So simultaneously, post surgery, you will restore the facial height, and these can be settled easily with the orthodontics. So what we do in these kind of cases, if posterior open bite is created, I will keep my splint there. Selectively, I grind the splint. I think my orthodontic colleague can easily understand the functional appliance therapy we'll do like this. We tell it that selective grinding. So you can selectively grind the area and teeth will superaerupt. In the open bite cases where facial height is increased, usually whenever any open bite case will come to our OPD, what we try to do, we bond the bracket, we give an anterior elastic and we close that bite, and we will be very happy. Oh, I have closed the bite, I have uh, removed the need of surgery. But the problem is that if already facial height is increased, you have placed the elastic and you have increased the facial height more. So you have settled the occlusion, but you have worsened the profile. So in these kind of cases, what we have to do, we have to increase the open bite more. We have to intrude the anterior teeth so that open bite will worsen. And when we are doing our surgery, we have to impact the maxilla posteriorly upward, which will create a open bite. Mandible will opto-rotate upward, which will automatically reduce the facial height. So simultaneously, you have settled the occlusion also, and you have solved the problem of the increased facial height. So it's a uh, after that we usually do the decompensation. Like usually in the class 2 cases, maxillary anteriors are tipped inward, and class 2 cases maxillary incisors are proclined outward. So we have to compensate them so that we have to procline the upper teeth in the class 2 cases and retrocline the upper teeth in the class 3 cases, so that we will get more space to move the jaw and reduce the discrepancy. So sometime bone will not allow us to uh, move the lower teeth outward, more outward, or upper teeth, lower teeth more outward or inward, because buccal cortical bone has a certain thickness. Beyond that we can't move it, and still we need a, good amount of uh, mandibular setback. If I need a good amount of mandibular setback and I am not able to procline the lower teeth more outward, then that reverse overjet will be less. I can't set the mandible back more. So in those kind of cases, these thing can be done surgically by maxillomandibular rotation. So if I have to take the mandible more backward, we can derotate the maxillomandibular clock downward, and if I have to bring the mandible more forward, we can rotate the maxillomandible complex upward. So this compensation you can do surgically. So, but for all those things, you have to plan prior and plan accordingly, because whenever you are doing the mandibular clockwise rotation, means maxillomandibular upward rotation, then you have to procline your lower teeth. You have to not borderly move. Yes, you have to just procline, because it's going to change the inclination of your teeth. See in that image C, when it's rotating up, inclination is reducing, it's becoming upright. So let it be procline, because usually we try to upright the lower teeth on the basal bone. So if we are going to rotate it maxillomandibular complex upward, then no need to bring the incisal on the right angle to the cortical bone. So this is case of maxillomandibular rotation. If you can see, there is minimal amount of the minimal amount of the overjet. So we have done the maxillomandibular downward rotation. Simultaneously, we have done the genioplasty, because chin went little bit backward. We brought it forward and downward. You can see the changes in the facial profile. So third thing is arch coordination. Basically, arch coordination refer to the transverse relationship between the maxilla and mandible. So whenever we will bring the maxilla forward, uh, mesobuccal cusp of the upper first molar have to fall into the mandibular groove. So arch coordination, in this photograph, you can see there is a posterior crossbite due to the anterior posterior discrepancy. But when we bring it into the occlusion, the posterior crossbite is going to be subsided. There is no posterior crossbite. Okay. So arch are well coordinated when the incisal tip of the mandibular incisor occlude behind the cingulum of the maxillary teeth, and the posteriorly buccal cusp of the mandibular teeth occlude into the central fossa of the maxillary teeth. So basically, for checking the arch coordination is better, you will take the maxillary and mandibular impression and then hand articulate it. Then you will get to know whether the arch are coordinated well or not. Sometime again, the bone is not allowing us to coordinate the arch properly. Then you can coordinate the arch surgically. It can be done with two-piece osteotomy or three-piece osteotomy. Once arch are coordinated, patient is ready for the orthognathic surgery from orthodontic side. So these are the pre-surgical checklist which have to fulfilled before sending the patient for the orthognathic surgery. Thank you. Basically, in orthodontics, we are not preparing just teeth. We are preparing the face for the surgery. If any questions are there,
Thank you. Very good morning to all of you present here. This is Dr. Priyadarshini. I'm a consultant surgeon working at GSR Institute of Facial Plastic Surgery, Hyderabad. So, my topic is going to be on virtual surgical planning and how we are going to use it. We have been using it in our day-to-day high volume cleft and craniofacial center. To start with, cleft orthognathics. This is the bread and butter. Almost on a regular basis, we operate on cleft patients for orthognathic surgeries. Unlike we think, it's just not the maxillary hyperplasia that we deal with in clefts. As you can see, the amount of dysplasia that we can expect is like quite moderate to maximum in most of the cases. And then it's also the complexity increases with other things like absence of bone at the cleft site or the quality of the bone that's usually present in cleft patients compared to the normal ones. The can't, as you can see in this particular patient. So there is also another big topic of how asymmetry is related to clefts, not only just with the maxilla, but also most of the times there's a lot of asymmetry that's present with overall facial skeleton. As you can see in this patient, there is also some amount of asymmetry that's related to the mandible. So virtual surgical planning helps us to do um, the prediction and the movements step by step and in a very precise way. So here we have planned for a maxillary osteotomy and advancement, a mandibular BSSO and setback along with the genioplasty. So one other important thing, the benefit of using VSP is that we will be able to precisely see how the occlusion is going to be post surgery. So in this case, like we have done, we have actually predicted there will be premature contacts at certain places, and then we can expect also open bites at certain places. So this helps our orthodontist prepare the patient prior to the surgery wherever there is a premature contact, doing a enameloplasty, and wherever there is going to be an open bite, he can plan it prior as to how to proceed with the orthodontic treatment after the surgery. So the precision is like up to millimeters. You can even decide like how much of contact is going to be there and prepare everything prior to the surgery. So another good thing is that we can also estimate the amount of positive overjet that we are expecting post surgery, and we can alter it during our planning itself. So, whenever we are planning to do a maxillary osteotomy and an advancement, for example, 10 mm of advancement, let's say, and then a lot of other things like pitch, roll, yaw, etc., and then post that, we can never actually judge the amount of bony movement that has happened at each position, like for example, the buttress and the piriform rim. So, VSP also helps us to analyze the amount of gap that we will be expecting between the bony fragments post movements. For example, in this case, we found out that it was around 4.5 mm at the buttress region on one side, 7.5 mm on the other side. So this helps us also to decide upon whether or not we will be going ahead with the direct advancement or with interpositional grafting. In cases of mandibular setbacks, it helps us to identify the amount of movement at the level of the tooth, at the level of the bone inferiorly, And also very important thing, whenever we are planning for a setback, we can actually measure the amount of bony overlap that's going to be there, the amount of proximal fragment that's going to overlap the distal fragment, and then measure it in the superior and the inferior border. And this will help us reduce the intraoperative time, because we exactly measure the same thing on the proximal fragment and then trim it accordingly prior to the plating. So in cases of advancement, we can also measure the amount of gap that is expected between the proximal and the distal fragment, which again reduces a lot of time in positioning. So moving ahead, we also operate a lot of craniofacial cases. Ones like this with Cruzen syndrome, an adult patient with severe maxillary hypoplasia, like you can see, and then she also has proptosis. So she came to us prepared for orthodontics, and you can see the amount of maxillary hypoplasia here. So there was hypoplasia at like different levels, right from the infraorbital region till the maxilla. So we had actually planned for a Lefort 3 advancement, followed by a Lefort 1 advancement, a mandibular setback, and genioplasty. So cases that demands so much of movements at different levels, of course, VSP becomes mandatory, because it's very necessary for us to position the Lefort 3 fragment in the proper place so as to decide where the Lefort 1 fragment has to be positioned. So we went ahead, did the VSP, did the osteotomy at the LIFO 3 levels, and then advanced it, and then visualized as to how much amount of advancement we achieve at each region, like the frontonasal, like the FZ, and also the amount of distance that we can expect at the zygoma level, so that we can fix the LIFO 3 fragment exactly at the position, and then go ahead with the LIFO 1 advancement. So after all the planning is done, we also get a soft tissue simulation of the same. This helps us to go ahead with patient counseling. It also helps us to actually relate how much of soft tissue impact the movements will have. A little more complex cases, another cruiser with also functional defects such as airway issues. She was having a severe OSA with proptosis and severe midfacial hypoplasia. You can also observe that the mandible is also hypoplastic. This patient was from another country, and she wasn't really interested to go ahead with orthodontics, beginning with 1 or 2 years of orthodontics and then go ahead for surgery. She was like quite in a hurry to undergo the surgery. As you can see the intraoral pictures, she had open bite and it was not properly aligned or decompensated. Looking into the CT, she had undergone a lot of cranioplasties before, so which there are a lot of defects that are there which didn't allow us to go for regularly for 3 or any such thing. So we had planned for a frontomonoblock advancement in this case. So we, in the stage 1, had done a frontal monoblock advancement distraction with RED frame. And during the stage 2, we had planned for the RED frame removal followed by a mandibular advancement for this patient. So in such cases, the frontal monoblock was already done. The patient is with the RED frame, and then we just know how much of advancement we have done. So we simulated the same in the VSP, and then accordingly we had planned for the mandibular advancement. So this surgical VSP was done prior to the stage 2. So the patient is under IMF still, and then she is coming for her follow-ups. So to move on with much more complex cases like this one, with a facial asymmetry, a patient with hemifacial hypertrophy, and then again she was quite similar to the previous patient, didn't undergo orthodontics, but she wanted to get her occlusion corrected. So the main aim of the surgery was functional correction because she wasn't able to chew well. So as you can observe, the OPG revealed a condylar hyperplasia on one side. And then you can also observe the amount of mandibular prognathism that she had. So CT makes it very much visible as to amount of asymmetry that was seen at the mandibular um, lower border level. We had gone in and done a bone scintigraphy to see the amount of, whether or not there is active growth, and there was increased uptake in the left condyle, suggesting a condylar hyperplasia. The most important thing with VSP is that you can actually try out a lot of treatment plan prior to you go on to the table and then do something. So first we had planned for a condylar resection, and then we moved the proximal fragment upwards, and then we tried with unilateral sagittal split osteotomy and setting into occlusion. We weren't quite happy with the final occlusion that we could achieve. So then we did the same with the bilateral sagittal split osteotomy and then setting into occlusion. But still, we weren't very happy with the profile that we could achieve. So again, we planned in for a Lefort 1 osteotomy, advancement, BSSO with mandibular setback, and then genioplasty. And then we were quite happy with what we could achieve, correction of asymmetry as well. And the facial heights were also quite satisfactory post the movements. And then this is the soft tissue simulation and clinically, as you can see on the patient. She's undergoing settling right now. So much more complex cases like TMJ ankylosis. So this was a patient who was operated for TMJ ankylosis release, and as expected, he did end up with a lot of facial asymmetry with growth. And then initially we had planned in to go for a maxillomandibular distraction. We printed a STL model and then we manually osteotomized it and then set the mandibular distractor, and then we simulated it on the STL model, and we could achieve the same on the patient in stage 1 surgery. So post this, we wanted to correct the amount of residual asymmetry that was present with genioplasty. So in these cases, it is very, very mandatory that precision is actually followed, because it was a very minimal asymmetry after the stage 1, but it did have a great impact on the patient clinically. As you can observe, the second picture is the post maxillomandibular distraction, and the third picture is post genioplasty. It can bring about tremendous change when done in a precise way. So this is another complex case of post-traumatic deformity, a gunshot injury. Patient was from another country. There was a combination of aesthetic as well as functional defect in this patient. He had almost no teeth anteriorly, and then the posterior teeth were all collapsed. So the main need of the surgery was to achieve some kind of occlusion with the posteriors and also bring forward the maxilla so that he doesn't look so odd. So again, in such cases, manual planning or doing a lateral ceph and tracing and all that is quite impossible because there's no teeth structure that's present. So we went ahead with the VSP, planned for a maxillary advancement and a mandibular setback in this patient, and this is what we could achieve. The patient is quite happy with what he is right now, and then he's waiting to undergo his second stage of surgery, which will be done 6 months later. So not only just for orthognathics, we also use VSP in a lot of other situations, like this case of facial asymmetry. She was a case of craniofacial microsomia, operated at our institute at a much early age for bilateral mandibular distraction. And she was quite happy with what looks she had, but except for the small defect that you can see in the left mandibular angle region, she wasn't ready to undergo any kind of major surgical procedure. So we went ahead and then did a mirroring of the other side of the mandible, and we could fabricate a custom made implant for the angle region. This is post printing and then, you know, post placement. This patient is still uh, under regular follow ups with us. So, stepping ahead, we do a lot of craniofacial cases as well, specifically in cases that needs precise decision making. For example, this is a very borderline case of plagiocephaly where the parents were quite um anxious and they wanted the child to undergo the surgery because they heard from a lot of other pediatric surgeons that it is not okay to have a plagiocephaly. So we had sent the CT of the patient, and then what we did was overlapping of the skull model of a patient of similar age, but the development was normal. So we just overlapped the normal skull with the patient's skull, and we could actually see the amount of discrepancy that was there and the volume difference that was there. So actually we didn't plan for any surgery for this patient, but it was really helpful for us to convince the parents, to show them, to educate them that the difference was quite minor and we need not go ahead with the surgery. So apart from this, The other very interesting thing that's available in the VSP is the airway analysis. So this is one of an interesting case where the patient had undergone palatoplasty, and then post palatoplasty they had reported with OSD. The patient did have any related other issues. So we went ahead, did a CT, and then we did a volume analysis of the airway. So in this, we can actually appreciate at what level the um, um, deficiency is in the airway. So we did note that there was a deficiency at the maxillary level. So it actually enables us even to analyze the airway post orthognathic surgeries. So there are a lot of studies that are still going on in airway analysis, and then developing it in the software that we are currently going to use. So gone are those days where we go on table and then decide what is to be done. Now we do a lot of planning well ahead. We simulate, we predict, and then we execute it on table. We have also observed that it reduces a lot of time, and then it makes the work also very very precise. Thank you for the patient listening. You can follow us on these social media handles.
Only one kind, one. One.
Okay, guys, thank you for the introduction. So, yeah, I will talk about today about the use of AI in OMF. So we all know that like AI has been like that topic which has been growing a lot over the past decade, not only like in medicine and dentistry, but overall in the daily life, how we use technologies. So if you take an example at like social media platforms, we know like Facebook has like achieved 1 million users within 10 months. Spotify required 5 months, Instagram 2.5. So the question comes, how long do you think ChatGPT required to achieve the same feat? Anyone here in the room? Number? 5 days. So it's not only about the speed, but also the quality of AI is improving tremendously. So if you look at like the image generator from Midjourney, so you can type in a name like Mr. Bean, Rowan Atkinson, and within seconds you will get the image, a real life image of him. And you can see between version 1 and version 5, there is a tremendous improvement. And if you look at the timeline, you can see these improvements were achieved within 1 year. So it's not only about the speed, but also the quality is improving tremendously. So what is actually AI? So if we talk about AI these days, we talk about neural networks, and neural networks, we try to imitate the human brain. We all know how the neuron is structured. So we have the dendrites where the information comes in. You have the cell body where the information gets processed, and you have an axon where the information gets transferred. With neural networks, we try to imitate these structures. So you have an input layer where the information comes in, you have hidden layers where the information gets processed, and then you have an output layer where the information gets sent forward. So let's try it with an example. So if you want to train a model which detects the number 3 in a text, so in the beginning, you need to provide neural networks with examples. So in the beginning of the training, the connections between the hidden layers, between each and every neuron, they are not well adapted. The model detects the number 1 falsely as number 3. If we continue with the training, we are slowly adapting the weights, the connections, we are improving it, and we can see that we are coming closer to the number 3. So the 8 shouldn't be seen as the number 8, but as the structure. So if you like half the 8 in the vertical dimension, you can see on the right side a small 3. And we go on with the training until the input matches the output. Of course, the models are like more complex nowadays, but in the basic fundamentals, they work the same. So we have different networks for different tasks, which also provide us different application possibilities. So in traumatology, one of our first projects what we had was to automatically detect mandible fractures on CT scans. So as I said before, we try to imitate the human brain, and so it's the same way we also trained the model. In the first stage, we trained the model to automatically detect the lower jaw. In the second stage, we tried to detect all the fracture lines, so the AI could color the fracture lines. And as you can imagine, if the fractures are displaced, then it's very difficult to identify the line. So we trained the third model to identify also these displaced fractures. So this is a model which we trained, and what you can do is like you can upload the CBCT scan, and in real time, the AI model will assess the scan, and within seconds, you can open it and you can see the results. On the left side, you can see the detection of the lower jaw, and on the right side, the detection of the fracture lines. So here as an example, as an images, so on the left side, you can see the original image. On the ground truth line, you can see the annotations provided by the clinicians in order to train the network. And on the right side, you can see two different networks with different performances. So of course, we tried to also compare these AI models against clinicians. So there were like 3 board certified clinicians from Italy, Netherlands, and Germany. And you can see actually, so well in precision as also in recall, the models were similar in terms of performance as the models. And if you look at the time, you can see that the AI models are like 2 to 3 times faster than the clinicians. And a second example is also where AI is frequently used nowadays is to recreate or reconstruct 3D images. So one of the disadvantages of CBCT is that the 3D reconstructions of certain structures are faulty. So we try to develop an AI model to automatically correct the condyle. You can see on the left side and on the right side, within seconds, it automatically corrects it. You can see on the left side the initial situation, on the right side then after the improvements with AI. So if you compare it to like manual corrections with the AI corrections, you can see on the right side there's almost like no differences between the manual corrections and the AI corrections. And if you look at the time here, it's almost like 50 to 70 times faster than the clinicians or the clinical technicians. Another use case which we develop now in oncology, I think it has also a broad use case here in India actually, is like to automatically detect oral cancer on clinical photographs. The first task was actually quite simple. So you take a clinical photograph, and the idea was to differentiate between healthy patients and patients who had oral cancer in the cavity. So we had a test set where we tested the AI model against, and the first results were promising. We had like 1 false negative and 1 false positive predictions. And if you look at like the clinical outcomes or the AI predictions, so on the left side you can see the original image, and in the middle you can see these called class activation maps. So what we try to do is we try to visualize which kind of pixels were taken in consideration for the AI to come to the conclusion. So if you overlay these activation maps with the original image, you can see that actually the area of oral cancer gets focused nicely. If you look at the healthy group, you can see there's like actually no activation at all, or very broad disseminated activations. And we try to improve these models further. So it's not the idea like to differentiate between healthy and oral cancer patients, but also like differentiate between other oral pathologies such as lesion, leukoplakia. So the idea was the same. We're gonna provide a tool to the primary care providers, GPs, dentists, that they can take the photos and the AI will automatically make the initial diagnosis. So you can see on the left side the initial image which was taken. In the middle you can see the annotations provided by the clinicians to train the model, and on the right side you can see the AI model predictions. And also here we can see in terms of accuracies and specificity and sensitivity, the model is in a range which is quite promising. Of course, it needs like further clinical validations, but the first results are promising. Also here we try to develop an web application, so you can see you can upload the clinical photograph, and within 5 seconds you will get an initial diagnosis of what it could be. We are currently working on like broadening this vision, so not only for oral diagnostics of like lesions, but also for oral hygiene monitoring, orthodontic tracking. So the use cases are quite broad. So coming to orthognathic surgery, we will later come in more in detail about the IPS case designer and what kind of like application possibilities are there. Of course, we are also currently implementing these AI algorithms into the IPS case designer. So you still have the old versions, but the new version will be released at the end of this year with multiple AI solutions in there. And one of the solutions what we tried to implement was the soft tissue predictions using AI. So you have in our department, we had like for every patient which we operate, we have the pre and post-operative 3D scan and also the CBCT scans. So what we try to do is like match the soft tissue changes to the hard tissue changes and train an AI model to automatically predict the soft tissue changes prior to the operation. So in the first project, we tried to focus only on the lower face. So only BSSO patients were included. You had like we evaluated the area of the lower face, lip, and chin. And what we could see is like if we compare it to the commercial models, we could see like a difference of 1 millimeter or below 1 millimeter, actually, like 0.5 millimeter, which is clinically absolutely acceptable. Now we develop this model further, also for biomaxes. So you can see here where you can upload the 3D photo and the CBCT scan. The AI will automatically detect the landmarks and put it automatically into a natural head position. And as soon as this is done, you can automatically simulate on the right side the movements, and the soft tissue will change accordingly within seconds. And if you compare here again, like the accuracies, you can see it's around about 1 millimeter, and also at a threshold where we see as clinician it's clinically acceptable. Of course, also for craniofacial cases, you can go and use AI, and this is a scaphocephaly patients which needed a further broad reconstruction. So what we do is like we match the pathological skull with the healthy infant and try to automatically remodel the bone pieces. This is currently done out manually by technicians, but the goal is that the AI will automatically set the pieces together. So here's like a case presentation, but you can see how the new pieces will be repositioned during the operations. Also on the lateral view. And with this, we can have like the surgical guides printed. So first we use like a marking template. So you exactly mark where exactly the osteotomy lines will be and where the cuts will be made. And as soon as you made the cut, you have like a negative mold where you can reposition, put the pieces together, plate it, and put it into the patient. So on the left side, you can see the initial situation, and the right side after operation. And with these technological implementations, we could reduce the operation time from 6 to 8 hours to 2 to 3 hours. And now we are also like working with robotics. So here's a video where we try, or where I programmed the robotic arm to automatically set the markings. This is the first step, but they are like you can attach, of course, a laser also to the robotic arm, which could make the cut automatically then. So these are like preclinical studies currently running. But this is the future where you can like see like from 3D technology to AI to robotics. So that's the end of my presentation. So I say like I usually say like three sort of clinicians. So the first group is like clinicians who make things happen. Then there are clinicians who watch things to happen, and the last group, I hope that nobody of you guys belong to that group, is like clinician who wonder what happened. Thank you.